Good afternoon, everyone. I'm grateful to be here, to be on the program with so many fine speakers, and to be honored by your group to be one of the bookends with Dr. Chan. It's special. So I'm grateful to Dr. Goodfellow, Dr. Russ, and Dr. Rangos, and for all of you who have come to participate. My topic is unfortunately not dispassionate. As we heard this morning, you have to be dispassionate. I've been involved with digital occlusion since 1984, since its inception. And because it has shown me so many subtleties that are impossible to see without it, it has become a very passionate subject matter for me. And as a result, I've been studying it and publishing about it in research forums since 1989. And so this presentation is going to address for you what is it about the occlusion that creates myogenous symptoms. And there are a lot of theories about the occlusion, what the problems are, jaw position, vertical dimension, balancing interferences. Well, when you measure the occlusion, you find out that it's really about timing. Timing is impossible to measure without digital occlusion. Timing of friction of the teeth, timing of periodontal ligament compressions, timing of force loading and uneven force loading, and it's just not possible to measure these things with static mediums like silicone, wax, articulating paper, especially articulating paper, which is an extremely flawed medium, although we need to use it. And for those of you who haven't seen a discussion about the truth about articulating paper, today your eyes will be opened about how poor a medium it is. I'm a consultant for TechScan. There's a company that makes the T-scan. I've been a consultant since 1998, 1997, but I began using the T-scan, as Dr. Friedman said, in 1984 when it was first built. And even though it had flaws in the system for a variety of reasons, things to do with the early generations, it preceded computers. You didn't have laptops, you didn't have desktops, you didn't have Windows, but it could measure time in hundredths of a second increments. Today it measures in 3,000ths of a second. And because of that, you can see incredible detail in the subtleties of the occlusal contacts that are impossible to see without it. And the timing is the thing that caught my eye back then in 1984. So I worked with the T-scan and published a number of papers about timing, foundation papers about timing, that led me to become a consultant. And I've published over 40 peer-reviewed articles, many of which are hard science, and many of which are also clinical techniques. And but I don't receive any compensation for sales. I'm not. If you get involved and have to purchase one, I don't receive a component of that, and I prefer to keep it that way. So, but just to give you an idea, this is the day that we saw Dennis's patient. She had been debanded, and her teeth looked like they fit. And I think it's important that you all understand. You may have heard me say it before. It's very easy to stand up here in front of you and show pretty end results like this picture, and the feeling is that it's good, right? It looks nice, the teeth look like they hit, looks great. But when you put the T-scan in there, you find out that the front teeth are getting overloaded, there's severe pressure on the right side, there's minimal contact between the back teeth except for one contact. And notice in the EMG of the closure, this is just a closure, two closure bites being made and one recorded. Notice in the EMG there's barely any masseter function. This is the masseter, this is temporalis. There's a lot of temporalis function recruitment, but not a lot of masseter recruitment, and that's because there's very little back tooth involvement. Only one contact really of significance. And this is a very important thing to understand. This is called the force center of force. It's a force summation vector, and as a movie evolves, it shows you where the forces are going. Well, this patient has extreme anterior pressure that builds, and when this goes out and across the front like this, and again, these are 3,000ths of a second increments shown to you in a static image, basically this person would have extreme anterior pressure for the rest of their lives, and you could never see it in articulating paper. You can't see the degree of pressure. You can see the contact surface area. You can't see the timing. You can't see the imbalances. You can't see the unevenness. You can't see the lack of tooth contact because there'll be paper marks on these teeth. But are they of any value
we give them value that they don't actually deserve based on science and research. And that's going to be something that all of you who haven't come to that yet will see today. There is no value in the quality of the paper marks. It's just surface area. That's all you're seeing. It's not force, it's not timing. So you can take this kind of thing and move the center of force down posteriorly on the midline, create more posterior tooth contact, and recruit more muscles. This is the same day. This was done in one day. And this maybe it took 6 or 7 or 8 recordings in a row using the data to create this kind of balance and this kind of end result. Now, having said that, the T-scan is very harsh. It'll challenge you. It makes you a much better practitioner. It doesn't say it's good if it isn't good. It doesn't say to you, yeah, it's perfect, Dr. Kerstein. You can go home now. It rarely says that. Only if you're very good with it does it say that. And so what it does for you is it says you can finish now, kind of. Or it says, no, Dr. Kerstein, you can't finish now. You're not done. It's still 65-35. The 3 teeth on the left are too forceful. 2 places on the right aren't touching. And they're not touching enough. And so what that does for you as a clinician is it makes you go further to known measured endpoints that are physiologic. And that's what the research about the T-scan has been showing all these years, is that these known endpoints that we can present to you as finished points allow you to optimize the human physiology. And that's what we're going to be talking about today. How to, for example, we tripled the mascular function in one visit. We tripled the temporalis recruitment and closure. And we did that without any therapy. We didn't do that by massaging the muscles. We didn't do that by injecting the muscles. We didn't do that by changing the head posture. We didn't do that by making appliance. We did it by optimizing the occlusion. And that's the value of digital occlusions. Known measured endpoints, high levels of optimization, precision, and doctor critiquing, saying, no, there's too much force here, here, and here, 3 places. You can do better, Dr. Kerstein. It doesn't tell you it's good unless it's really good, and that helps your patients dramatically. So I want you to keep that in mind. In 1991, I published a paper about what disclusion time really is, and it was seen with the T-scan 1. Without the T-scan, we couldn't see it. And of course, there were always these concepts of you want to have immediate posterior disclusion, right? Everybody tells you that. And yesterday, again, I really enjoyed listening to Clayton speak. He said, you know, the camps are all coming together. Everybody, if you go to anyone's occlusal camp, they're not going to say, no, we don't want immediate posterior disclusion. We want prolonged extended disclusion. We want all that friction in the bite. We want all those teeth rubbing together. No one's going to say that, right? They're going to say, we want immediate posterior disclusion. But immediate implies timing. And your timing can't be seen with your eye. So that's what's missing. Again, the disconnect is, for example, here's another timing point. We want to have bilateral simultaneous contacts. What does that mean? It means that both sides of the arch and all the teeth should hit at the same time. So how do we know that it's happening at the same time? We look at paper marks and we say, oh, there's contacts on all the teeth. It must be happening at the same time. But not when you work with digital occlusion. You'll see many things happening in 0.2 of a second or 0.3 of a second that you can't see with your eye. And so the power of the T-scan is allows us to see things like disclusion time, even in T-scan 1, which was cryptic compared to T-scan 3 with turbo record. But it could see time, and that's been its greatest advantage. It allows you to see force as well, which is also a very important advantage, but the timing is the secret to using it well. So here's the patient we just looked at. Same day, after their disclusion time was changed from about 4 seconds to 0.242 seconds, which is a specific process of treating the occlusion. Now, it can be done by adding to the canine some, it can be done by reshaping the teeth some, and it can be done by basically closing the vertical and coupling canines and then treating the occlusion. So I'm going to show you examples of all of that. But look at the EMGs. The same patient, the same day. Look at the hyperactivity. It only remains slightly in the right massive. And again, the harsh reality of using measuring devices. If you use measuring devices, you see it doesn't come out as perfectly as we'd like. I'd like to see this be gone, total flatline, but it's not. But when you look at it between the pre-op and the post-op of the same day, look at the change. I'll get out of the way here. Look at the amount of muscle activity difference that the same excursion creates. And the thing to note in this these two recordings is the C to D increment. From C to D is the disclusion time. Look at the difference in the distance between C and D post-op and C and D pre-op. Right? So this is the change. How fast the back teeth come apart is what C to D means, and we'll talk about it in great detail. So here you see the patient moves to the left, and their teeth maintain frictional contact for a long period of time, and they don't really reach their front teeth till here, which is almost 4 seconds. Well, here it happens in half a second, but actually 0.242 seconds. And look at the physiologic change. This is why you can work without appliances, because you can actually turn this off by treating the occlusion, which treats the periodontal ligament compression. That's the secret.